Hello, everyone, and welcome to today's Keynote webinar titled Diversity, Equity, and Inclusion in Cancer Research, the Promise of Stakeholder Engagement. This webinar is part of the Cancer Research and Oncology 2021 event. I'm Christina Todd of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots. Now let's get started. Before we begin, I would like to remind everyone this event is interactive. We encourage you to first participate by communicating with the other attendees using our new live chat feature during the presentation. You can find the live chat located at the right of your screen. You can also participate by submitting as many questions as you would like during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. If you have trouble seeing or hearing the presentation, click on the Help Desk button located at the bottom of your screen within the navigation bar or from the lobby. Finally, as a reminder, this presentation is educational and offers free continuing education credits. Click on the Continuing Education Credits link located in the Abstract window below the presentation window and follow the process to obtain your credits. I now present today's speaker, Nadine Barrett, Assistant Professor at Family Medicine Community Health, Director at Center for Equity and Research at Duke Clinical Translational Science Institute, and Associate Director at Equity and Stakeholder Strategy at Duke Cancer Institute. For a complete biography on our speaker, please visit the Biography tab at the left of your screen. Dr. Barrett, you may now begin your presentation.
Wonderful, and thank you so much, Christina. I really appreciate that. And I certainly appreciate all those who are part of this incredible conference over the past 2 days, all the work that's gone into this, and most certainly being invited to give this talk today and to kind of share a little bit around our opportunities that we can think about and potentially incorporate in our work as we think about increasing diversity in clinical trials. As I said, one of my key areas of interest is always thinking about how do we work toward increasing diversity in clinical trials. And it really happens, actually goes way back for us to start thinking about what that looks like. And so today we're going to really just go through a session, a talk, if you will. It's part of a training that I call Just Ask. And halfway through this session, you'll understand why I call it that. But it is an opportunity for hopefully you'll be able to build some strategies or ideas or thoughts that you can actually go back and brainstorm with your research teams to start thinking about how you can work toward increasing clinical research and clinical trials. So that being said, again, I have great excitement for all of those who are doing this great work, and hopefully as we think about the work that we're doing as researchers in the cancer and oncology space, that we can really start thinking about how do we work toward engaging ourselves, our teams, and our collaborators in this work together to become more intentional in increasing diversity in our trials, and what does that look like? What do we need to do to be able to be most effective? So again, thank you, and I'm looking forward to it. Now, a key part of this, Christina mentioned earlier as well, just so you know, that part of this talk is actually also interactive. It's, in fact, quite interactive. So I always encourage people to use the chat. I may ask questions, and as I ask those questions, I would love for you to be able to put your thoughts and your comments in the chat. I can see them and actually be able to respond to those as well. I'll add some thoughts around that space, and so as we go throughout this afternoon, I'm looking forward to having you all share your thoughts and your perspectives in that space as well. So when we think about diversity, and we ask the question, what does diversity look like? We can look at this picture here, and you could even start writing in the chat if you so choose, to start thinking about what kind of diversity do you actually see here? And I'll give you all a second to kind of think about that, because it's really important as we think about increasing diversity to ensure first we know what we're talking about and what we're referring to when we say diversity. So feel free to put it in the chat as you go along, but key to that is really thinking about all these pictures and what do we see. And so some of you may say race, you see differences in race, maybe ethnicity, certainly age is a part of that as well. So you can see some of the pictures. You have younger people, people who may be older, and even senior citizens. There's also different types of relationships that we're seeing in this picture as well, that we can make assumptions about what those pictures and those relationships may be. We see ability. We also see opportunities around, as I mentioned, ethnicity and culture as well. Thank you. I see age, gender, race, perfect. Feel free to continue to use the chat to see what else you see here. Does anyone see some differences maybe around culture, differences along those spaces as well? And so what we typically do when I show this slide is that, just as it's already been highlighted in the chat, and most certainly if you all refer to it and look at it, you'll see all different types of perspectives, right? So we think about, for example, the woman in the hijab, the second woman from the top, and then also the women that are on the fourth row, second row down. And we can make assumptions or thoughts about, oh, they must belong to a particular culture. And just because people wear a certain attire, it doesn't necessarily mean they subscribe to all that we may believe that that culture is, but they most certainly may be dressing that in that way, probably to be culturally appropriate in that space, particularly if they're visiting certain countries, or they may actually ascribe to many of the or most of the beliefs that goes with that culture. And that those cultures include your language, your beliefs, your spiritual beliefs, your religious practices. All of that is a part of the culture and the norms as well. So oftentimes here we also see there's relationships that could be husband and wife, it could be a family unit, etc. And I always look at this picture, and depending on what audience I'm speaking to, who I'm engaging with, there are oftentimes, if you look on the top row, and it's about 1 to the 4th picture in, and you see the 3 women that are there kind of in together, and one of the women is in the color yellow. And so when I ask the question around diversity, people oftentimes will say that this picture looks like maybe a mother and her 2 daughters, or 3 sisters. And in some cases, some people actually look at the picture and say, actually, that looks like a mother, her daughter, and maybe her daughter's partner on her wedding day. So again, depending on the perspective and our views, we can actually look at these pictures and have our own thoughts and perspectives around it, and it could very well be different from someone else, even though we're looking at the exact same picture. So when we think about what diversity looks like, and as we go throughout this day, we're really talking about diversity across the gamut, diversity in age, in race, in culture, in sexual identity. We're also thinking about it in the context of religion and able-bodied, in size. All those are different ways in which we are diverse in our society. And we're thinking about all of that, and particularly in the context of those who are or may very well be marginalized or underengaged in research and underengaged in healthcare. So when we look at this diversity, well, some of you may be familiar with this picture here. It actually came out in National Geographic many years ago. But if you look at this picture, I would ask you, what's the race of the people here? Who's Black? Who's white? Who's Hispanic or Latin ethnicity? Who's Asian? It's hard to tell, right? And yet when we look at this picture, the idea was that by 2050, the diversity of the United States would look more like this, right? It's growing more and more. And in fact, now the data shows that it's actually not by 2050, but about 2036 that we anticipate seeing this. And so when we talk about addressing race and ethnic disparities in access to care, quality care, and participating in research and clinical trials in oncology, or any type of study for that matter, we do have to ask that question, what does race look like, and how are we going to start thinking about that as we move forward in our work, as we think about engaging our patients based on who they are? It becomes important to recognize where that fits. Perfect. So this is the question here. I think there's a little lag there in the slides. Okay, great. So here again, this is the picture I was referring to. And again, in 2050, this is what that can look looking like. And in fact, the data is now starting to say that this is probably going to be more around 2036. So again, just highlighting the importance of that. So when we think again about the first picture in terms of our lens and how we see pictures or people and how we could all have different perceptions there, likewise, as we think about this and what we may think or ascribe someone to as being Asian or Latinx or Black, it's hard to tell when we start thinking about that unless we find out more about that person and what their values are and actually how they even self-identify. But it really is important as we think about how we're going to address health disparities, think about it and engage our patients and our communities in a meaningful way based on this diversity that consistently changes. So normally, if this was part of a workshop that I do, we would actually go through a whole process here of looking at these pictures. But typically when we do this, I actually ask questions around what characteristics stands out to people here in terms of who's warm and who's competent, who do they think they will feel more comfortable engaging in a regular daily conversation with, or in some cases seeing people, if your car broke down in the middle of the night, which one of these persons, if any, would you want to show up and which would you rather not show up? What kind of thoughts we have about women who may be a beauty queen, as the woman is in the bottom left-hand corner, or the man at the top in the black jacket and the black shirt who looks like he's in a workshop. So we go through this whole process, and people have different perceptions and perspectives around who's warm, who's not, who they think would be most relatable, and who they would not be. And it's interesting because I use this exercise primarily to help people to understand that, one, we have different perspectives and experiences, and all of that plays into our perceptions around who we think is trustworthy and who's not, who we think is going to be able to understand what we have to talk about when we're providing medical care, and who may not understand or may not follow through with the recommendations as a provider because of certain assumptions or thoughts that we may have about that person. And when we go through this exercise, it's really an incredible one when people get a sense of that. So again, in some of these cases, some of these persons here are actually not what most people would think that they are. And that helps us to start thinking about how we ascribe certain perspectives or thoughts or characteristics to people that may not necessarily always fit. And so all of these factors, whether we're looking at a picture of women who we think are sisters or a mother and daughter, and yet they may actually be a lesbian couple getting married, whether we're looking at the diversity in terms of what we see as race and ethnicity and how we ascribe certain characteristics like the color or the complexion of one's skin to a certain race, the way in which someone's eyes may be shaped or their hair, the texture of their hair, all of those are different ways that we make assumptions, or we, in our minds, start to think about who is from what race, what group, what population, and then also start to think about what characteristics will connect to that. And what happens is in this process is that we all, if we were all in a room today, we would see that they would be very different. We would all have very different perspectives along those lines. It happens every single time I've given this talk, whether the audience is 300, 1,000, or 20 people. It always shows that we have different views. And it's shaped by multiple things, including the media, including how we were raised, where we grew up. In some cases, I could be teaching with students, and they actually have never, this is their first time now as undergrads, for example, actually being around a population that is different from their own. As we know in the United States, the most segregated time in the United States is actually between the hours of 9 a.m. and 2 p.m. on Sundays. That is our most segregated time, and that's usually when people are worshiping, which they typically worship with people who look like them. And so all of these then mean that when we think about and we have these perspectives that are shaped by all these different factors from the moment we're born until whatever age we are now, we've been socialized to think about groups in different ways based on our experiences. And so that leads to our perceptions that could actually lead to what we oftentimes call blind spots. And so I'm going to show a quick video to kind of give us a sense of what that is, and then we'll move forward into the rest of the session.
Are you seriously considering her as a candidate?
Just don't trust.
She's a woman.
She's a woman.
This is a man's job.
She's clearly not educated.
Really? Does she even speak English?
That's not me. I'm not like that. You call it an honest mistake. Science calls it a blind spot. Our unconscious mind is a mysterious and powerful thing. It makes 90% of our decisions without us even knowing it. Our brains are overloaded with 11 million pieces of information every second. Yet we can only process about 40 of them. So we're wired to make cognitive shortcuts, using past experiences to make assumptions. And you know what happens when we assume. Our unconscious mind can put us on autopilot, determining where we sit, who we eat lunch with, who we turn to for advice, and who we choose to offer a helping hand. Living our lives with blind spots can put us in a tunnel. Same point of view, same decisions, same outcomes. We can find ourselves trapped in the land of snap judgments and misconceptions. We've all been on both the giving and receiving end of blind spots. Think about it. Who's talented? Who's able? Who can I trust? Who belongs? We've all been there. Blind spots are part of the human condition. Our choices have consequences for us and the people we interact with. By accepting that blind spots exist, we can stop. imagine what possibilities exist if we could do it all over again. Different perspectives, inclusive relationships, diverse networks, better outcomes, seeing people for who they really are. People like you with unlimited potential. We all have blind spots. Once you accept that you have them, you can choose to do something about it. It's time to check your blind spots and focus on what's possible.
Excellent. And so what we learned from that video is really highlighting what we've known and what we've talked about briefly already in this conversation, is really thinking about blind spots and how our perspectives and our views are often shaped by the views that we have as we see or we're exposed to diverse populations or people who may be different from ourselves, who we are, who we grew up with, our family, etc. And so these blind spots play a part in so many ways. And so when we look at the pictures that I showed earlier, along with this video, we also know that when patients are coming to an encounter with a provider, that usually, or just not even just patients, just people in general, when we meet someone new, we often within about a 30-second to 60-second at the most, but within a 30-second period, have made about 60 assumptions about that person. And those assumptions are based on multiple things: their height, their hair, how they hold your hand, how they shake your hand, how strong or loose that may be, where they're from in terms of their accent actually can play a part in how much you feel like you can lean in or not into the conversation. And all of that plays out. So we're getting all this information and we're making decisions about how we will interact, how much we think that person is capable of understanding everything that we have to say, and also assumptions that we may even make about their ability to follow through with the regimen or the treatment that we may be providing. But this happens again across the board. So regardless of whether we're in a public setting, we're meeting someone at a coffee shop, or we're meeting someone in our clinic for the first time as a patient who just heard the words, "You've got cancer," or we're meeting a colleague for the first time who's new or starting or interviewing for a position. In all of those settings, there's all kinds of perspectives that we all have that's based on our experiences. And these are often referred to as implicit biases or unconscious bias, and some of you may have heard those terms before. And in this case, we found that historically, there's a lot of studies, a wealth of studies that go back for at least a good 40 years, 40, 50 years, if not more, that have really highlighted how these biases or these perceptions play out in terms of impacting health disparities. So, for example, we know that doctors assume, in studies that have shown that providers may assume that Black or low-income patients are less intelligent, more likely to engage in risky behaviors, and are less likely to adhere to medical advice. And so this impacts, these studies showed that it actually impacted the kinds of treatment that they were offered, the type of engagement and conversation that they had, and what that communication looks like. We also know that there's differences in pain medication prescribed to Black patients compared to whites. It's also the same thing for Asian patients as well, where their pain medications are oftentimes prescribed at a lower rate compared to their white counterparts. We also see a wealth of literature. Sean Wheeler and others have done work looking at pregnant women who face discrimination from healthcare providers on the basis of their ethnicity and socioeconomic background. So oftentimes assumptions that a woman may be on Medicaid when she may not be on Medicaid, or assumptions that she cannot afford to take care of her care when she's trying to get healthcare for her pregnancy and her delivery. We also see clearly marked women present with cardiac heart disease symptoms, for example, are significantly less likely than men to receive diagnosis and referral and treatment compared to others. And so what we tend to see is that a young man or a male or a female may very well show up to the emergency room, and there's a wealth of studies now that have shown that men get treated differently from women when they show up to the emergency room, although they may both have symptoms of what one may say are the beginning of potentially a heart attack. And so what we find in that space is that women are more likely to be asked questions in the emergency room about stress, anxiety. Are you going through a lot of stress? Do you have children? Are there issues going on at home? How's work going? Things along those lines, whereas a man is more likely to be actually taken in, not asked those questions, but are more likely to go through the full battery of tests and more likely to even stay overnight. And so that plays in part for why men, although women may have heart attacks more than men, men may have heart attacks more than women. Women are more likely to die from a heart attack compared to a man. Again, that's not the only reason, but that certainly plays into that. And part of that could be that if you kind of go back and think about a man and a woman who show up at 60, if you could rewind time and take them down to when they were about 2 years old, 2 years old or so, and they both are kids, and they're running, and the little boy falls, and we pick him up, and we're like, oh my goodness, what is our response? We're typically more likely to use a stronger voice, say, dust it off. We're not as likely nationally to pick him up, but more likely to just dust him off and say, you're okay, you're strong, you've got it. Whereas if the little girl falls, we're more likely to pick her up and cry, almost use a crying voice with her, where we're saying more like, oh, poor baby, oh my goodness, oh, did it hurt? Let me kiss it better, oh, and cry with her. And so as we think about this, then we're almost teaching little boys to not show their feelings, to not have the same kind of response to pain as they expect the woman to. Where the little girl, we're actually encouraging her to kind of just crying and letting it out and kissing it better. So these are studies that have shown this for a long time in the sociology and psychosociology field. And it really plays out in terms of how males and females are groomed growing up to actually not show their feelings. And so some make the argument that when you fast forward from this child, and I just have to say this, I have been a complete culprit of it myself. My own godchild, his little boy, was running, and I teach this all the time, and he was running, and I literally stopped when he fell, and I looked for a crack in the ground just to show him, I'm like, look how strong you are. You've actually cracked the ground. Wow, you're so strong. So even I, who have been doing this work forever, still has to catch my own biases in the way that I may be feeding into some of that. So then when you fast forward these two children into the point where they are now adults and they're showing up at the emergency room at 60 years old or so, they're more likely to actually be seen as, well, we've been telling boys and men to hold back their feelings, to not show emotion, to not show their hurt. And so if they're showing up in the emergency room, especially since men typically don't engage with the health system at the same extent as women and over the same time as women from the age of adolescence forward, that now they're showing up, they must be in serious pain, and so they're more likely to go through the full battery of tests. Whereas women have been kind of shown to express their feelings and their perspectives and their hurt in a very different kind of way over the years, and so the assumption is that the woman must be going through some other things, and this may not necessarily be a heart attack that she's going through. So again, this is just another example of how these biases play out. So is it a national conspiracy then in emergency rooms across the country that says if a man shows up, take him right through? If a woman shows up, ask her some questions to see if there's a problem? Absolutely not. We know that there's no national conspiracy in emergency rooms across our country, but it's interesting that we do have a national trend in our country around this space as it relates to emergency room and experiences. And part of that is because of the socialization that we've all been socialized in different ways to think about groups, to think about male-female roles, to think about gender, race, and assumptions that we play in all of that. And they play out as well, as much as we don't want them to, they do play out also in how we provide care, how we interact with people, whether it be in the grocery store or, as I said before, in our clinics. And so implicit bias and this unconscious bias plays a part also, as I'll share momentarily, in some studies that have been done in the oncology space as well within cancer. So when we think about this, then I also always think about then what are the factors that we need to think about and where differences lie? Because if we have these blind spots, as we just saw in that video, that means that the perceptions that I may have of a group or you may have of a group may be different, or we make assumptions that everyone gets the same thing. So in this case here, when we talk about the prism of difference, these are some of the social categories in which we do differ, right? And so when we think about race, ethnicity, age, sexual orientation, when we think about religion, there's so much diversity in our world and across the globe that all of these factors play a part in our perceptions depending on how exposed we are, and one, and two, where we fit in within any of these categories, right? So if we think about religion, for example, I often ask people, are we living in a country where in the United States you can actually practice whatever religion you believe in? And most people in the room will say, absolutely, without question, yes, this is the land of the free, this is freedom of religion, that's what we do, that's what we're founded on, all of these factors. But it's really interesting because when I start going deeper, I say, well, what does that look like? So policy-wise, absolutely. But what does that look like in practice? And so we start talking about that. And what we find then, of course, and we're using religion as an example here, when people come and they are looking or they're working, for example, and they look at their time where they want to take time off for religious practices, it just so happens that our Christmas breaks for school systems and even where we work oftentimes rotates around Christmas time. So in December, and even Thanksgiving for that matter, we're more likely to have time off, right? Schools are closed during that time. Likewise, spring break, it just happens to happen right around Easter, which happens to be a Christian holiday. So if you're talking about Ramadan and other holidays that happen for people who may be Muslim, Jewish, etc., those holidays don't typically fall within those times where our school system holidays typically fall. So people actually have to take that time off. Sometimes it's personal time for them to be able to actually practice their own religion. So when someone's maybe a Christian, for example, we may not necessarily recognize that, oh, we're getting a privilege in terms of when we get to celebrate our holidays compared to others. And so again, that's just one example of how even if we have policies, it doesn't necessarily mean in practice it really works for all people of diverse backgrounds and experiences. Likewise, when we think about what we value in our country, right, or in our globe, when we think about these categories again, we also can start thinking about it in the context of race, for example, where we can say we have Black, white, Asian Pacific Islander, etc. And we oftentimes can think about, and you'll notice some changes now, most certainly, but you'll often think about, what group is most valued in that space? Men and women, what group is most valued? Oftentimes, most people in the group and in the chat, people will write men compared to women. Others will say white compared to other races. And there's societal norms that actually play out that reinforces that even when we don't realize it ourselves in our day-to-day lives and our day-to-day experiences. There's always a story of what kind of income do we prefer, right? And so we talk about the Joneses. I have to be careful when I talk about the Joneses now, because as we get older, the younger generation are like, who are the Joneses and what are you talking about? But those of you who may relate or may remember, like keeping up with the Joneses, what does that mean? Who are the Joneses? Where do they live? They typically live in a very suburban neighborhood or a very urban neighborhood downtown somewhere. They also, in the urban areas, it's usually a big house, 2-car garage, white picket fence. All of those things are the stories that we value. If you look at our commercials on television, our commercials actually still give that kind of sense of this kind of upper middle class lifestyle as being the one that we all should be aiming and shooting for. And so again, when we look again at all these different prisms of difference, we'll see differences in terms of what we've been exposed to, and therefore that shapes our perspectives, it shapes our attitudes, it shapes our biases. I often use another example of Columbine because what happens is these groups become invisible. So when we talk about the school shootings that happened many years ago, and I know we just recently had another one over the past couple of days, but most certainly back in the day, we had a rash of school shootings, particularly one that we remember with Columbine. As sociologists, they actually explored to see, well, how is this being depicted in our society? And what we found was that essentially the Columbine shootings, for example, was that in the news and on the media, and whether it be in the newspaper or on the radio or television, it was this constant discussion around kids killing kids. Why are kids killing kids? Well, it wasn't really kids killing kids. It was actually boys that were killing kids in school. But in the media, it kept saying kids killing kids. It wasn't just boys killing kids in school, but it was actually white boys killing kids in school, right? It wasn't just though that it was just white boys killing kids in school. It was actually white boys who were middle class who were killing kids in school. And so what happens when we say kids killing kids versus if it was, for example, African-American, Latinx, or if it was women, white women, they would actually be called out and say, what is happening with the women? Why they're killing the kids in school? Why they're killing their peers in school? But in this case, it was kids killing kids. And the challenge with that is that the kids then, the white middle-class boys, were not getting the help that they need. And interestingly enough, white middle-class boys are the #1 purchasers of rap music. And when asked why, they say because they relate to feeling isolated or not connected. And so again, these kind of highlight and speak to this invisible nature of when we talk about these categories, the ones that are most valued tend to be invisible. So we talk about black on black crime as if white on white crime doesn't happen. And the reality is that people tend to commit crimes with people who look like them because it's usually within their neighborhood or people that they know. And so more than likely, most cases across our country, trends is that people tend to commit crimes against people who are typically the same race as they are or ethnic group. So, but what happens is that there's invisibility that goes with that, and therefore assumptions that goes with that as well. So when we talk about this, I always want to highlight that when we talk about stereotypes, we talk about unconscious bias, we all have it. So it's not like one group has it and the rest don't. We all have it in all of those dimensions that I just showed in the previous slide. And the reality is that we're more likely to recall information about people that we don't typically have much exposure to. And so those, the recalling of those assumptions or those perspectives are based, as I said before, on media, based on where we grew up. If we grew up in a neighborhood or a community where we did not have much diversity, then as our perceptions around people are going to be based on what we see on TV, what we read in the media, and what people tell us about them, whether it be our friends and our family. And so therefore, we're more likely to recall that information when we see people of diverse backgrounds as well. And when I say diversity, I want to be very clear here that people oftentimes think diversity means Black, Latinx, etc. Diversity means everyone, because if you think about a Crayola box, there's also a white crayon as well. So diversity, if we're really going to talk about, we're talking about everyone as to the diverse pool, not just people of color or underrepresented groups or terms that we may use like that. So I think that that's really important to highlight as well. And so here, when we talk about these stereotypes, it's almost like a white car. I just recently bought a white car. I've never noticed how many other white cars are out there. But now that it's in my head, because I have one, I see white cars everywhere, and almost all the other cars become invisible because I notice the white cars. So that's how these things are perpetuated as well, is that we see it, we hear it, and so then because we hear that story, when we see someone act or respond in a certain way, we're going to pull back from those things, our resource, if you will, as the video showed, the 11 million messages that we get, of which only 40 of them we can actually truly process. So that being said, then, when we talk about these areas and we talk about the disparities that exist, as I just mentioned in some of the other slides, as it relates to oncology and other areas, we also then have to really highlight some of the work that Camara Jones and others have been highlighting around the difference between equity, equality, and justice, and particularly between equality and equity, because equality and equity is that when we look at these stereotypes, when we look at these experiences and these poor health outcomes along the lines of socioeconomic status, along the lines of race, rural, urban, LGBTQA populations, in all of these areas, we tend to find that people who are in rural communities, people who are sex and gender minorities, people who are underrepresented race and ethnic groups, and women and other gender groups most certainly experience worse outcomes as it relates to cancer and other chronic diseases as well. And the goal is that people often think about in the 60s that we want to focus on equality, right? Well, equality means that, as you see in this picture, everyone gets a stool, but not everyone still gets to realize the goal, which is to actually participate fully in this journey called life, if you will. Equity is a little different. What equity does is really kind of creates and recognizes that there are systemic challenges and barriers that impact people not being able to participate in clinical research and trials, and also ensuring that they have the best health outcomes from prevention all the way to survivorship and even end-of-life care. And so when we look at equity, we actually implement these different resources or tools, if you will, to be able to ensure that people get to live out their best optimal life or their best optimal opportunities as it relates to care. Now, the reality is that when we look at this, we typically use this as resources, like things that we need to do to provide access to good quality care, right? And so if people need 2 stools to do that, we give them the 2 stools. If they need 1, they get 1. And that's kind of how equity, the framing of equity is. But I'd actually kind of start to think about equity a little bit more different. And as you can see here in justice, it's that everyone actually gets to see, regardless of who they are. And in fact, the more recent pictures of this, they have taken out the fence completely. It says, once you remove the fence, then you've actually removed all the systemic and structural barriers that impact people being able to have full access to care, whether they live in a rural community, whether they're a race and ethnic or gender minority, or whether or not they are living with poverty. So I really want us to think about equity in a very different way, and that's how we can start to really think about how we view, if you will, the opportunity to increase diversity in clinical research and trials. So I often liken this whole idea of those stools to more of a marathon. And so if you think about a marathon, and if you guys can just join me on this journey for a quick moment here, you think about a marathon, we're all standing, we're ready to go, and just as we're ready to go, we let the gun go, bam. And the person who shoots the gun goes, bam, white men start running. Keep running. Keep running. Keep running. All right, 100 years, bam, white women start running. Keep running. Keep running. Keep running. 150 years more, bam, black men start running. Keep running. Keep running. Keep running. So now we're at 400 years. Bam, black women start running. Keep running. Keep running. So when you think about this marathon and everyone running this race, if you will, what happens is that as you start the race, if you're starting at the front, you're going to create systems, and back then, created systems, the education system. They created the criminal justice system. They created even the institutions of religion. They created education, criminal justice, healthcare systems, and who gets access, finances and the financial industry. All of these things are created so that even as white women start running, they have to start jumping over obstacles because some of those things were not created with them in mind or created with them intended for them to be able to thrive in that space. The same thing happens when you think about every other race and ethnic group and every other disadvantaged group, economically, financially, or sexual gender minority. As they continue to run this race, if you will, you'll continue to see that the obstacles are there because the systems were not intended for them to be able to succeed, if you will. And also, not only do the systems then work in favor of those who create it, but there's also the benefit from it multi-generational, right? So the wealth, et cetera, gets passed forward and forward. And so when we talk about equity, we're talking about trying to close those gaps. And those gaps are pretty significant. And that means that those gaps play out in every area of our lives, including diversity in our research and clinical trials, recognizing that most of our studies in the past have mostly included white male. And then over time now, we see more white male and females in clinical research and trials. But we still see this gross underrepresentation that COVID has highlighted significantly of underrepresented race and ethnic groups, as well as other underrepresented groups involved, people in rural communities not having access to clinical trials that could actually be significantly beneficial to them. So when we talk about equity, we're talking about equity from that standpoint, where we're really wanting to actually work toward being a part of changing that and being equity ambassadors, if you will, as providers in the clinic. And so here, this is just another example of when we look at the diversity in clinical research and trials. We know most certainly here we have race and ethnic groups most certainly are least represented in 10%, less than 10% are represented in our clinical trials. The same is true for oncology, whereas almost less than 2 to 9% of underrepresented groups are actually involved in clinical trials. 2 to 5%, 9% total are actually involved in oncology trials. And so again, highlights the fact that we have a significant problem, a lot of work to do. And the question is, why do we see such lack of participation? We know many of those reasons are related to policies that now we know in January 2022, new policies are coming into place to expand Medicaid in such a way that a patient can now receive standard of care that will be paid by Medicaid and be on a clinical trial. That was not the case before, so that's a huge win for us. There's other policies that are currently being drafted in Congress that we've been a part of toward actually increasing opportunities for more diversity in our trials. We also know that we don't have enough diversity in our workforce and in our research teams, and that plays a part. Our research teams need to mirror those who look like us, who look like our community and the patients that we serve. And being intentional about that is really important. We also know that many of our studies, our consent forms, et cetera, are not available in other languages. And so if you don't speak English, you have a less chance of being able to participate in a clinical trial that could actually improve your quality of life, potentially even save your life or at least the life of others down the line. We also know that in terms of where clinical trials are available, typically tend to be around more academic health centers and not necessarily in some of our community-based clinics, and most certainly not in our rural communities. And so these are some of the key barriers that play a part in lack of diversity in trials. We also know historically that there has been a lot of medical atrocities that happen, both historic and current, that has impacted particularly people of color and other underrepresented groups as well in being able to trust research. And it's not so much that they don't trust it as much as that research and our healthcare systems have not truly been trustworthy enough to be able to make people want to actually build trust. And so it's a big work that we're doing now to really start building that trustworthiness to actually help to improve both access to health care, access to quality care, and access to clinical research and trials. It's also that these broader systems that I mentioned in a marathon plays a key part in that as well. And so we can't ignore that people are not just living within our bubble of our cancer world, they're living in a broader society that has not necessarily always been open to the diverse populations and perspectives that people bring. And so most certainly it plays a part in terms of how they engage with the system. There's also lack of information that goes out into the community. One of my big things is that people in our communities need to hear about clinical trials and research before they ever hear the words "you've got cancer." So that when and if they hear the words "you've got cancer," or their family member hears it, they hear there's possibly a clinical trial for you, it's not the first time that they're hearing about it. They're knowing about it and getting more knowledge around that. So how do we engage our communities in a way that we can be proactive in that space? I've mentioned the system barriers already, and as I mentioned already, there's some challenges associated with the opportunities for us to really create a more trustworthy environment in our health systems and in our cancer centers. So why is this important? The reality is that if we're going to really use this framework of equity and ensuring that everyone has access to your studies and our clinical research and trials, and this includes biospecimen and biobanking donation as well, that in order for us to really do great research, we need to make sure that we're producing rigorous science. And as the NIH actually has highlighted and continues to highlight, that the data that we have and the data that we are all using in our oncology studies and research across the board is just too white. And it is not allowing us to be able to make the generalizations that we should be making and should be able to make. We're not able to do and fully explore differences between race and ancestry, which we know that those two are very different concepts. Ancestry being related to your genetic ancestry and makeup, race being a social construct that is actually based on political terminology. So race changes as we go through our lives, from being black to Negro to colored, all changes. One point it used to be black, white, yellow, red was the way in which our races were described. So race is very much so politicized and very much so a social product and construct versus genetics and ancestry. And there's also some research coming out now in oncology that's showing that you actually see different outcomes and different outcomes when you use race versus when you use ancestry looking at health outcomes. And so again, really making sure that we can explore those differences requires a diverse pool of participants and biospecimens. It's also important for us to improve outcomes and reduce disparities. And also, as I mentioned before, it allows us to produce equitable care. So the question here is that why are people of color not participating in clinical trials? The study has always been, and the argument has always been, because they don't trust the systems, they don't trust healthcare. Well, in fact, with the number of studies that are coming out now, mine, some with Reagan Durant, some with my partners both at UCSF and at Roswell, we're all learning and realizing through our research that actually it's not so much that people of color do not want to participate in research and clinical trials as much as that they're not engaged and they're not being asked. And there's a key study that actually came out here that also noted in my study here, factors associated with participation, bias and stereotyping, and unexpected findings. So more and more studies are showing that people actually do want to participate. They just want to have a conversation. They want to learn more so that they can be able to make an informed decision, just like we do with any other healthcare decision-making process. Also, we found in a study that was actually done by Reagan Durant and 9 images of center leaders, principal investigators, research coordinators, and teams, but they found that bias and stereotyping was a key part of the impacting their perspectives around minority recruitment in oncology trials. And this study is an important one because it really highlights and documents what we know exists in clinical care. Why would we think it doesn't actually happen in clinical trials as well in oncology? In this study actually started to change the narrative because in this case, the research teams actually in qualitative interviews talked about that they saw minority participants were perceived as being challenging to work with or a challenge to deal with, so they oftentimes just don't ask them to participate. Some of the research team's PI said that they're not perceived to be ideal study candidates, and so when asked or probed why, there was not much clarity around that. We also see that the providers were withholding clinical trial opportunities from potential minority participants or underrepresented race and ethnic groups because they were thinking the clinical barriers or other factors might be a problem. And this is before they actually looked at fully the person's full profile or even talking to the patient about it. So we know then in many studies is that the number one reason why most people participate in clinical research and trials is because they were asked, they were informed. And the number one reason why most people don't participate, they had no idea that clinical trials could even be something that they could explore. Even if they know that they may not qualify for it, it would have been great for them to actually know about it. And again, this gives us the opportunity to start thinking about how do we ask and how do we engage our communities and our patients more in clinical research and trials. And so now I'm going to go through a few quick examples of how we've been able to do that. And then highlighting again that the lens that we see in the world often shapes how we interact, how we frame our research, our policies, and how we even practice medicine. So this is a study here that we did. A quick short version of this is that basically I partnered with the River Church. One of our researchers, Dr. Mira Epline, focuses on H. pylori. As we know, this is the bacteria that when you have H. pylori infection causes stomach cancer. We worked together with the church for a year, and after a year, the bishop actually says, why don't we bring a clinical research study to our church? And so we actually opened up a clinical study where we did blood draws, the urea breath test, the questionnaire to really explore H. pylori infection. 25% of the 92 people that participated in this midweek service event actually had H. pylori infection, in which we were able to then navigate them to a PCP, and we had 80% cure rate over a 6-month period because we lost 2 people to follow-up, but again, 6 people. Again, highlighting where we're both addressing a need, but we're also creating opportunities where we're bringing clinical research out into our communities and going beyond those doors. Another great example is what we have here, which is Equal ACP. This is a study looking at advanced care planning among race and ethnic groups, particularly between blacks and whites, actually. And what we know that there's a sharp difference between black and white populations in terms of who's actually having advanced care planning. And we know advanced care planning improves the communication, improves people getting what they need and what they want, and their values followed, and ultimately getting what they need at the end of life, if that is the case. And so advanced care planning is really critical to that. So we have 10 clinics across 5 states, 800 adults, half black, half white, that we're actually recruiting for this study. It's a 5-year study, and they're being followed to see how we can actually engage community health workers in this space of this clinical trial. We're testing 2 different methods of doing advanced care planning. One that is more intensive, the other one is more self-guided, and we're looking to see, are there differences if you have a black provider, a black community health worker who's actually helping to do the advanced care planning program, if we have race concordance, discordance, if we have a black patient with a black person that's helping them with the advanced care planning, do we see differences in the likelihood to actually do advanced care planning or not? And we do the same for white. So these questions are really important, but we're doing a strong stakeholder engagement process. We're actually engaging stakeholders at each of the sites. Instead of having one advisory group, we actually have one community advisory, 5 of them at each of the sites and at their clinics, so that we can really recognize the nuances that are happening at the local level. This is another way in which we were actually able to engage. And I will mention from that last study as well, is that there was a point where we were recruiting more white patients compared to black. And so what we ended up doing is slowing down to looking at what the challenges were, and we actually made the modifications. So we constantly, in every meeting, talk about the recruitment strategy. And this should be consistent whether or not this is a health disparity study or not. This is another study that actually was really 4 studies that actually are within prostate cancer for metastatic disease. I actually work very closely with Dan George here at Duke, and with the Abby Ray study in particular, we're recruiting African American and Caucasian men or white men. And what we found in this process is that we were actually recruiting more white men than African American. So we actually stopped and slowed down and brought in, made more intentional efforts to recruit African American men to the Just Ask program. Through the program and the training, we were actually able to meet the goals and end on time. What was really incredible, both with Abby Race and then we see now with these 3 other studies, in that in each of these trials with either hormone therapy, chemotherapy, or cellular therapy, African American men entered the trial with worse disease but responded better to therapy. If we were not doing these race stratified studies and we were not making sure that we had the right representation, we would never know these types of findings. And it makes us wonder, what are the things that we're missing in our studies when we're not being intentional about engaging diverse populations in our clinical research and studies? So these are some key strategies that we've implemented through that. We did the Just Ask program and all the ones that I've mentioned. We also ensure that we work toward making sure that we were being intentional in meeting our goals around the diversity of enrollment of women and African American and Latinx populations. And in each of these studies, we're being successful because we're actually making it a part of every meeting that we have. We also focus here on some other strategies where we actually reach out to our community and our patients who are on their studies. And so we both do community assessments, we engage our community partners. And so oftentimes our community actually makes referrals for patients because they know we're becoming more trusted and they know where they can actually get the kind of care that they need if they hear the words you've got cancer. We also work with our Latinx populations to actually help us develop our consent forms, our recruitment materials, so that it can actually be available in Spanish as well. We're also doing the same now to reach some of our Chinese populations in our area. Again, really highlighting opportunities to make sure our materials are critical. So as a final step here, this is some of the key things. I always say, and it's always important for all of us that are doing work in this space, that a recruitment and retention strategy in clinical trials without a diversity plan and a budget that corresponds with it is not a recruitment and retention strategy. Unless we're being intentional in that space, we have missed the mark, and that's our blind spot by thinking having a recruitment and retention plan and identifying the number of people that we need under each of the categories for Table 4 is enough. We have a lot more work to do in that space, and being intentional with our teams makes a huge difference. Making sure we're addressing the language barriers and compensation in that space, making sure, as I mentioned before, monitoring your studies so that you know when to slow down so you can make sure that you reach your goal, and you will reach your goal on time if you're being intentional with it and using the right strategies. Having community and patient stakeholders on our studies have been incredibly important, and we encourage all of you to think about that if that's something you're not doing now, and to also develop patient advisory counselors in that space. It's also important to make sure that we're talking about implicit bias and how that may be impacting some of the work that we're doing and identifying opportunities in that space as well. We also ensure and encourage our clinics to engage as critical partners, our community, and engage our community clinics. The ACCC, Association for Community Cancer Centers, and ASCO have done an incredible job in really pushing us forward in engaging community clinics as partners in our increase in diversity. So we're reaching the rural communities, we're reaching urban communities, we're reaching people who are poor, we're reaching the diversity of race and ethnicity as well. And then there's also importance of increasing diversity of our workforce. What does our research staff look like? Do they look like us? Or do they look like our patient population? It's important for us to ensure that that happens so that we can make sure that our patients, as they engage with our system and engage with our care, that they also are fully aware of seeing people that look like them in the community and in providing care. The last few things here are really related more to the one-on-one encounter with that patient. Patients actually say that they would rather providers and research coordinators speak to them more in terms of a conversation versus a transaction. So sometimes participating in a clinical trial or asking to participate can oftentimes be presented as a transaction versus a conversation. That means thinking about how our tone is, what we're saying, incorporating the why you're asking them to be a part of that study, and how they can be a partner instead of of a subject in a clinical research study to actually help advance science and lead toward a cure. So those are the conversations of the community and our patients that they want to hear, even if they know it may not be beneficial to them, being able to hear that they are a partner with researchers, with science toward addressing these issues is critical to them and important, and it's more of a conversation than them feeling like it's a transaction and engagement. These other points that are highlighted is really ensuring that we're consistently doing the work that we need to do to address the needs. And last but not least, I'll invite everyone to look at the implicit association test that's actually on Harvard's website, and here's the site here. There's also a video called the Just Ask video. Feel free to watch that as well. Both of these will help us to recognize where our blind spots are so that we can provide the best care to our patients and invite the diverse populations, to participate in our studies by being culturally responsive, sensitive, but also doing the work that we need to do to be able to be effective in addressing that care. And that being said, thank you all so much for your time. Thanks for being a part of this session. And again, thanks to all the planning committee for inviting me, and really hoping that as you're here today and you think about these studies and these strategies, that you can apply them in your own backyard, in your own work, so that we can be able to move forward. Thank you so much. Have a great day. And I think I'll pass it back to you, Christina.
All righty. Thank you, Dr. Barrett, for the presentation. We'll now start the Q&A portion of the webinar. If you do have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen. Let's get started. Our first question is, how can I get started incorporating stakeholders in my research?
That's a great question. There's multiple ways in which you can do it, but I think one of the key parts is, first, if you're a part of an academic health center, to connect with your cancer center outreach group, as well as engaging with your clinical translation science institutes as well, CTSAs that may be there. If not, it's still important for us to identify who are the stakeholders in our community. There's a lot of community coalitions that meet. There's faith organizations in your community, and work together to identify who are some of those leaders, at least 5 or 6 of them, bring them together, get their insights and input, and then develop an advisory council. And then that your patients, so as you think about your patients, both as participating in trials, some of your patients who participate in clinical trials could be some of the best ambassadors that you could possibly have. And so they are ambassadors in the community to talk to the community, where we actually have sessions where our research teams or our clinicians will actually go out in the community with a patient and talk about what it means to be in a clinical trial. We've moved that now, due to COVID, onto the Zoom platform, and it's been incredibly effective. We have about 100 people sometimes that show up on these sessions just wanting to hear and learn more about clinical trials, and COVID has brought that even more to the forefront. But those are some of the key steps that I would take to move forward in that, developing an advisory council and moving from there.
Thank you for that. We also have one more comment. This is greatly seen in South Africa. People just assume all people are African. However, there are many different cultures in South Africa, and all with different genetics. That was from the audience. And then
that was a fantastic point, and it's a huge point that I think, we were talking about the U.S., but I would say that our global studies as well are obviously showing the same thing. And so it's so important for us to not make assumptions, even from a global standpoint, right? In terms of when we say Africa, everyone thinks Black. And it's not quite so much. Africa is quite diverse too. So thank you for that comment. Excellent point.
I was going to say that one hits home for me, because one of my very close friends is South African, and people always get confused because she's white. But do you have, Dr. Barrett, any final comments for our audience?
No, I just hope that as you all continue to do the work, and whether it be biospecimen donation and identifying people who can give their samples for your basic science and translational research, or if it's engaging our patients as participants in our clinical trials, I really want to encourage you to think about the Just Ask program and other types of programs that can really help you to implement the appropriate strategies. But being intentional and making sure that your recruitment and retention plan has a diversity strategy. And if you don't have that, identify experts who can help you to be able to outline what that diversity strategy is and what that budget is. And it will benefit all, and we actually will be able to contribute to addressing health disparities through our research. So thank you all so much.
Thank you again, Dr. Barrett, for your time today and your important research. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand for 2 years until October of 2023. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. And until next time, goodbye.